Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back. This is Jeff Dikis, and this is Pod Patrol. Joining me tonight is Dr. Ellie Nasser, the residency director at Geisinger out in Scranton, Pennsylvania. Thanks for joining me tonight.
Thanks for having me, Jeff. This is really awesome. I'm excited to be here and really enjoyed listening to some of your podcast recordings, and I'm excited to talk tonight.
Yeah, absolutely. So you went to Temple, and then you did residency there at Geisinger, the program of which you are now the director. So take us back to school and kind of walking through your externship selection process, because there's a lot of students kind of going through that process right now. So how did you end up selecting that program?
Yes. So great question to start. So I'm, from the Scranton area. So I was born here. I left and went to Boston for 4 years for my undergrad and then ended up at Temple. And so when I was looking at externships, I know many will say, don't pick your externships and your programs based on a geographic basis. But I did. And I'll say that while I agree with, don't limit yourself for a variety of reasons, everybody's lives are different and everybody has, different focuses and family and maybe things that are going on in their personal life that might sway them one direction or the other. I'm very, very close with my family. I have a lot of siblings. They at the time were living in New York City and Philadelphia and, kind of that general region. And so that's where I chose to do my externships. Mm-hmm. I remember, being very torn as to staying in Philadelphia or coming back to where I was originally from, which was Scranton, kind of knowing or hoping, I guess, with my life that I would end back up there at some point. I just didn't know if residency was that time or if I was ready for it yet. And I remember being worried, am I going to get the same caliber of education in a rural area like that as opposed to a bigger city like Philadelphia, or am I going to see the same types of cases? And when I externed, it answered the question for me. We were, we were a level 2 trauma center, and we still are, but we get cases sent to us from all of our surrounding hospitals. So we get a lot of pathology, a lot of trauma, a lot of diabetic limb salvage population, which is what I, really came to focus a lot of my career on. And so at the time that was kind of made the decision for me, and I decided to come back to my roots and do my training there. And to this day, I still kind of promote that when we're talking about our residency program, when it comes to the types of education and the cases that you'll see and the variety and complements that you'll get there.
Yeah, absolutely. So that makes a lot of sense. And it is a well-known program. It's historically well thought of. So it wasn't just you went back to your hometown. Oh, by the way, it's a good program and well thought of. So that was beneficial as well. So you went to residency there, and then you did a fellowship, but then you kind of stepped in to be an attending at that same program. So I can guess that would be a very difficult thing to do. When I was in Pittsburgh, the now director, Jeff Manway, was a third year when I was a student. And so when I became a resident, it was his first year as an attending. And so you're used to kind of treating them like a friend, a colleague, hey, buddy, what's up? And then all of a sudden they become an attending, and that relationship is still friendly, but it has to change a little bit. So how did that process go from you jumping from resident to fellow to attending all at the same program?
I mean, it was a lot for sure, but I'll say that the program at the time was very tiered and structured, and that there was a lot of upper year teaching younger year residents. And a lot of programs are built that way, right? So
Yeah.
the chiefs are teaching the second and the first years. And so there was already that structure. So I don't, the transition seemed a little bit more natural to me at the time, especially with that fellowship year built into the, into the middle of it.
Sure. That makes sense. You didn't
Yeah.
go from third year to
Yeah.
attending. There was a little bit of a,
Yeah, that buffer year. But that being
yeah.
said, what I think is challenging is trying to incorporate teaching when you're immediately fresh out, right? So it's like your first elective case in the operating room,
Mm-hmm.
or your first, and so trying to. There's a delicate balance between still being able to teach, trying to get that education experience for the resident, but also, you're trying to figure out your way of doing things at the same time. We're really fortunate, and then we just hired 3 of our graduates back to Geisinger this year. So they just graduated residency the end of June, and they all started in August. And
Wow.
and they're all navigating that right now, right? Because they're working with residents in the operating room, as of August. And so it's not an easy thing, I think, to try to figure out, well, I need to figure out my way of doing things, but I also want to teach and incorporate that as well.
Yeah, and it's hard because you're in boards collection. Even if you don't
Yeah.
realize it right away, you are, as from day one, you're logging cases, you're in boards collection. So you want everything to go perfectly smooth, because that resident someday will be
Yeah.
off somewhere, but you're the one left behind looking at the x-ray going, I don't know, I think we could have done that one better.
Yeah.
Maybe. But
Yeah.
that's what you have to keep in mind when you become an attending, and instantly someone else is involved in the case. So I don't know, did that factor into your thought process at all? Like, you can help, but you have to sit over there.
Well, you don't really get the liberty to have the liberty to do that, right? What I will say is, the orthopedic process is shorter than our process is in terms of their case collection. And I've had a lot of new hires, or probably most of them, say, until I get my cases and I'm board certified, I'm not working with residents. It's not just podiatry residents, it's any residents at all. So I found that to be pretty common in the ortho world, of just saying no.
Right.
In our world, I mean, I love teaching. It's my favorite part of my job. It's what brings me the most fulfillment. It's what brings me the most joy, and it always has. So I think that I don't know if I thought about it probably as much as I should have back at that time, when I was collecting my cases. And I think that, but it's definitely something that should be on everyone's radar, maybe a little bit when they're first coming out.
Luckily, in my experience, they tended to pull the most recent cases.
Yeah.
So maybe that doesn't factor in quite as much as you thought when you first got started, but it gives you a little bit of time to kind of get your feet underneath of you, knowing that anyone listening, they tend to pull cases that are more recent. You kind of figured out some kinks in how you want to do stuff as you move along. So you're now the residency director. Was that always your goal? Is that always something you thought of? Okay, I want to be maybe not there, or maybe yes there, but okay, I know I want to be involved in teaching, but I want to be a residency director. It just kind of happened.
I think a little bit of both. I've always loved teaching in every capacity of my life. I taught swim lessons, dance classes. I was the pro sector for the cadaver lab when I was at Temple. So I always was teaching in some capacity. And I think it was made probably in residency and fellowship where I realized how much I loved teaching podiatry. And so that just continued to blossom and grow. And I think I mentioned that I pretty shortly after I joined Geisinger, I became the associate program director, and did that for about 4 or 5 years, and then kind of grew into the director role. So I don't know that I graduated residency and thought this is my 5-year goal or 10-year goal, but I knew that teaching had to be part of my career. And that was going to be really, really important to me. And I think I'm fortunate to be at an academic institution. We're affiliated with the medical college, and that I'm able to, dedicate time to teaching. We have really great academics and research program and things like that.
Sure. So what exactly are the roles of an associate director? I assume it's mainly to figure out what a director does, so that when it's like, vice president of a club, okay, when the president moves on, then I can become the president and know exactly what they did. But what were the roles as an associate director?
So we're a pretty big program. We span 12 to 15 residents. And so part of it is, I think, sharing some of that workload a little bit. I think every program is different, and we've figured out what works in our program. So right now, the associate program director and I have kind of worked our way into settling in our different roles. She creates our academic calendar, our grand rounds, things like that, like some subsidiaries of work that are that I can kind of delegate a little bit, and she can be creative with, and she's really grown those programs into something wonderful. She joins a lot of, about half of our academic sessions, if not more. She's a great soundboard just to, hey, like this is going on. What do you think we should do? And then we have a core faculty program that we meet with quarterly and discuss our residents and feedback on them and things like that. So you can't go into the CPME website and say, this is the program director role and this is the associate program director role. But I think that, from program to program, it's what flows, what works best. And I have 3 kids. I've been on 3 maternity leaves. And so she filled in and not just filled in, she embraced that role and really, did such a fantastic job that I was able to walk back into that part of my job, knowing that everything was taken care of perfectly and very well, and with a lot of dedication and a lot of passion and compassion.
So let's talk about that for a minute because, for those listening, they may know my wife is a podiatrist. So I understand the role of mother / surgeon / 10,000 responsibilities going on all at the same time. You are one of the few female residency directors across the country. How do you kind of make all of that make sense? How do you make all of that work? I think it's probably a complicated answer that involves good support systems surrounding you. But what are your thoughts on how to make that function optimally?
Yeah. So it's a very good question and one that I get frequently, and it's something that I'm pretty passionate about. I want young female students to not feel like they ever have to choose between their career and a family life. I think it's taken me, so I've been in practice 10 years now since fellowship, and it's taken me a while to fine tune what's important to me and where I can start saying no to things. And that's really helped a lot. I think when you're first out in practice, you want to say yes, right? To every opportunity. You want to build a reputation and build a patient base and build a connection with different physicians in your area. I still do a lot of volunteering. I felt like that was a very great way for me to network within our profession, and it's brought me a lot of opportunities. But somewhere along the way, you can't keep doing all of it, right? And somewhere along the way is when I started having kids. And so I think that's when I started to be able to scale back a little bit and try to think about what means the most to me, what fulfills me, and try to not say yes to absolutely everything, but still give back to the profession in a way that's meaningful, and but also be able to have time for my kids and my family. A lot of the academic things, this included, is my kids are asleep. They're in bed, right? And that's so many of the different committees that I'm on. The meetings are usually around 8 p.m. And so I feel like I'm able to do that and participate in these things without it taking time away from my family. Certainly it takes a lot of support. I'm fortunate to have my mom and mother-in-law within 10 minutes away, 15 minutes away. And since my kids were born, they've been really, really vital in their upbringing and really, really helpful.
Yeah, I get that question a lot as well because we're a two physician couple and we have 2 young boys. And so what I always tell people is, I don't know, you just kind of figure it out. You just kind of go day by day and you figure out, okay, what's today going to look like? And some days, we have a sick kid. Well, you take a half day and I'll take a half day. Then we'll move all my patients into the morning and then you move all your patients into the afternoon and we'll just kind of make it work. So day by day, you just kind of figure things out and make it work.
For sure.
What would be your advice to externs? So this time of year, late fall, early winter, students are going through the extern selection process. They're picking the programs that they want to spend a month at 4th year. And you're having externs come through that are eventually going to be selecting which residencies they want to apply for. So you have a firsthand knowledge of seeing these people on a daily basis. What is your best advice for externs coming through the program or any program to do a good job and potentially set themselves up for success?
I think what we're looking for in externs is We want them to be interested, to be engaged, to be on time. And I mean,
These are very basic
it is,
things.
and to
And
get, and
you'd
to
think
get,
that they would have these down.
yeah, and to get along with others. You know,
Yeah.
we'll have 2 to 4 students every month, and they're from all different schools, and we pay attention to how they interact with each other, right?
Sure.
And you want to see the groups that complement each other and that support each other and aren't don't have more of a competitiveness to them. You know, I'm less concerned about whether or not you know the answer. But more concerned about, can you try to figure out a thought process maybe as to how
Mhm.
to get there, or have the drive to go home and look it up and talk to me about it the next day. So I
Yeah.
think that, we've been really blessed this year with great students. We really have. And some of those best qualities really are just, what I mentioned, working well with others, supporting the residents, the patients, and just being interested, engaged, asking questions. We do something called a debrief after our surgery days. I was in the OR today.
Mhm.
And so I sit down with the residents that I scrubbed with, and we talked about what went well, what didn't go well, what questions anybody had. And the student that was scrubbed in with us all day had so many fantastic questions, like
Mhm.
really thoughtful. And it just showed me how engaged she was all day, and how she was really kind of critically thinking about the work that we were doing, not just going through the motions of, assisting in the case and writing the sapahemic card. And, she was there and learning. And she was making me think with some of these questions, and they were very, very thoughtful. So that's what impresses us.
Yeah, absolutely. So I work with students. Some students come with me on a 1-month rotation. So I have students most of the year, third-year students. So even a little earlier on than you're seeing them as externs. Hopefully they're a little more polished by the time they get to 4th year, and even more polished by the time they get to residency. But I always tell the students that I kind of judge them not based on whether they know the answer or not, but how they respond to not knowing something. I find far more information from someone in judging how they accept not knowing something or understanding something. Do they get defensive? Is there just a long pause where they're not willing to say, I don't know, but I'm going to look into that because I feel like I should know that, and tomorrow I will,
Yeah.
versus just this long, awkward pause. Like, I think there's a lot to gain from how people respond to knowing something, yes, but also how they respond to not knowing something.
That's a great point.
Yeah. So students, when they rotate through with you in the OR, I think there's 2 modes of thinking. And I remember this when I was out on my externships. There's 2 options. One is stay out of the way. You're not employed here. We don't need you. We can function without you. Stay out of the way. Don't bump into anybody. Or number 2, why are you sitting in the corner? Get a pair of gloves on. You can certainly help hold this leg while they move the patient, while they roll, while they do whatever. Get your hands in there, get dirty, grab the tourniquet, get it going.
Yeah.
Help us do things. What is your thought process on how students should interact?
Oh, we want number 2.
Yeah.
Every day, 100%. We want them to be part of the action. And I mean that sincerely. We try to get them as involved during the surgeries as we possibly can, allowing them to practice some skills. Even I always, today do we add an Aiken or not? I had everybody vote in the room. I let the student vote, yes or no, should we add it? So I try to engage them as much as possible, in real time, both with hand skills, or even if someone's observing, like showing them this is what's on the C-arm and this is why we're doing it. But I want to see them jumping in, grabbing dressings. I do a lot of inpatient work as well. And so seeing them, just jumping right in to that care, I think is really impressive. And that's definitely what we want at our program.
Sure. So we're lucky, and I was talking about this with the student who's with me right now. We are lucky in that, because they're in the process of picking their externships, that we get to go spend a month interviewing. Basically, it's a 2-way interview. We're deciding whether we like them and if they like us, vice versa. But we are lucky in that a lot of other specialties don't get that opportunity. They don't get that time spent at this place. Point of this question is, when you have externs visit for a month, do you feel like you get a pretty good understanding of what they'll be like as a resident? Or has it ever caught you off guard that how they were as a student was actually quite different than how they turned out to be as a resident?
We've been caught off guard, for
Yeah.
sure. And it's surprising because you think that's a month. A month is a long
Mm-hmm.
time, right? I mean, a month is certainly more time to get to know somebody than one interview, right? That might be
Yeah.
45 hours. Ours are 45 minutes at CRIP, as even maybe an interview plus a couple visits. So it's definitely more time than that. But I will say we've definitely been surprised in both directions. We've had students that came through that were good, but not excellent, that are beyond excellent residents, and we've had students that came through that were our number one rank and maybe didn't perform quite as well as a resident. So
I think that's a little bit surprising maybe for people to hear, but that was my experience as well.
Yeah.
You think a month is certainly enough time to find out who someone is and understand what they're all about. But I don't know what the point of that was. I just found it interesting that you think you're getting one thing and maybe you do and maybe you don't, or maybe it's better or worse than what you thought. So let's spin that off on talking about what makes a good extern into what makes a good resident. What do you view as, the externs can only do so much. They don't work there. They can show up on time. They can be helpful. They can ask good questions. But when they take it to the next level, what makes a great resident in your eyes?
Yeah, I think a lot of the qualities are similar. I think being a team player is so important, right? You need to have each other's backs, and your lives will be so much better for it, right? We've been pretty lucky with our classes where they're constantly, checking in. They're on off service, but before they go home for the day, oh, you're slammed in the ER. Let me help you. Let me do this consult for you, and so you can get home earlier. So I think that's really important. That I think also it's just being engaged. You have to be organized. It's so much happening at the same time, right? Because it's not just patient care. You're learning a new healthcare system. You're learning a new EMR. You probably have some sort of research responsibility. You have other presentations that you need to put together and schedules and call. And a lot of that's probably new, right? Trying to navigate, this real new job with these different hours and things like that. So I think that there's an element of organization and multitasking that's important. So, but I think that being a team player is one of the overarching things. I think that could take you a long way.
I would agree with you. I think that's probably the most important thing. Whether you're a good surgeon, whether you, help with rounding, all that stuff is fine. But if you work together with your residents, you get along, it is such a better experience for everyone involved versus if there's, a squeaky wheel and then there's causing some problems, especially the bigger the residency, the more potential there is for some issues if one or more people kind of don't get along or don't mesh. So I agree with you. I think that's a huge component of that.
Absolutely. I mean, we don't expect them to come to the program being great surgeons, right? They probably have barely done any surgery. I think that's what we're there to teach them. We're there to teach them to be surgeons, and we're there to teach them how to, run a busy day in the office. And so that's, that'll come. We've got 3 years to teach you that, but it's really hard to teach getting along with other people and kind of just some general professionalism principles and just overall positivity. I think that goes a long way.
Yeah, that's kindergarten stuff, right? Like, do you play well with others? Yes or no? That should be pretty basic. So right now we in the US have pretty much standardized 3-year surgical residencies. What are your thoughts on whether you feel that's enough time for people to garner enough experience to do what they should be able to learn? And then what role you think fellowship plays in plus or minus adjunct to that existing residency model?
Yeah. I think that 3 years is sufficient. I think that, it's been around for a long time. I know that the transition to all of the programs to 3 years is more recent, but I do think that it's adequate. I think that I did do a fellowship. So coming from personal experience, I think that it helped me the most in my confidence. And as a transition year, I felt like I was half a resident and half an attending. And I had some autonomy and I did some cases on my own, but I always had to phone a friend, and I still did a lot of things, underneath my residency director. And that was really important for me. I can't say I learned a specific surgical skill. I can't say that I came away doing something different that I did in residency. And some may argue then why spend an additional year doing that? But for me personally, in my hand, that confidence was really valuable. And it's something that I think, really helped me to grow as a surgeon and as an educator. So I think it may come down to what the resident is looking at specifically. There are some fellowships that do specify in something. Pediatrics. Maybe you didn't get total ankle replacements in your program and you want to do total ankle replacements when you go out and practice. That's very appropriate. So there are some that are very specific and there's others that aren't. There's others that are just kind of general, almost like an extension year of residency. And I think that that comes down to that, the specific trainee and what they're looking to get out of that fellowship. And if they feel like that would be valuable to them in terms of their goals and what job they're looking to get.
Yeah, I think that's very reasonable. So as of right now, fellowships seem a little bit like the Wild West.
Yeah.
There's been some well-established fellowships that have been out there for a long time. There are some newer fellowships. That doesn't mean they're not as good as the established fellowships. It just means they're newer. But I would argue that there are probably some that aren't quite as good. And there are maybe some people who are using that as cheap labor. So in your mind, how do we potentially limit the misuse of fellowships and really make sure that the fellowships are adding something to the educational model rather than kind of treading water for an additional year?
Yeah, that's a very hard question. I think that, well, there's two different accrediting bodies, right? So they're not all accredited, if they're accredited at all, right? So at first I would advise the resident that's looking into a fellowship to make sure that it is accredited. And then maybe there can be some discussion as to looking more specifically at what's involved, case minimum, specific categories, but I don't have a perfect answer to that. I think that if residents are looking at fellowships, probably the most valuable thing they could do is to talk to the current fellow, right? See the real-time experience. What are they getting? Is it, another year of residency and they're on call a lot and they're not really gaining more surgical experience? Or is it what they are looking for? Maybe more surgical autonomy, maybe a specific type of case that they didn't get a lot of.
Yeah, I think that makes sense. As society has sort of shifted, just like it always does, the 80s were different than the 90s. My kids the other day said, "Hey, Dad, back in the 1900s." And I said, "Please don't call it the 1900s." But the 80s were different from the 90s. We get the idea that society changes with time, which is for better or worse. It's just going to consistently change. But I think that we're starting to do a better job of understanding the role that mental health plays among the general population, but especially in the medical field. Historically, residency has been a time of, not everywhere, but potentially resident abuse, overwork, not so mental health friendly. So what are your views on how we can balance supportive mental health environment? But at the end of the day, we got patients to see, we got surgeries to do, we got patients to round on. That takes a certain number of hours. Maybe that's unanswerable, but what are your thoughts on how to balance that?
I'm glad you brought this up. I think it's really important. I don't have a perfect solution, but I can tell you it's something that we think is really important at our program. And we've put together a lot of initiatives over the past few years and continue to grow them. So we actually have a well-being champion for our program. There's so we're part of a health system throughout the state of Pennsylvania that has over 500 residents, right? So within our GME department, there's a well-being department, and then each program has a wellness champion that provides additional funding for our program. It helps us to get involved in other sort of initiatives that the other programs run. But even before that, we do wellness half days. So all of the residents get 4 wellness half days just built in, and we do it when they're on service because we feel like that's when they're the most burned out. And it could be to go to your PCP appointment or the dentist or get your oil changed. Or it could just be to go home and lay on the couch, whatever you need to do. But
Sure.
So that's something that we've done for probably 3 or 4 years now. We have a clinical psychologist that does check-ins with our residents each PGY. She'll kind of meet with them individually. That's kind of flew in throughout the year.
I think that's interesting because mental health is a moving target, and sometimes the people who need the most help aren't willing to ask for it. So
Yeah.
almost instilling some, assistance along the way that's just expected, I think is a good way to handle that. Sorry I cut you off. Keep going. But I
No,
think that's a very important
it's nice
point.
because it's like I'm here for everybody, right? No one's getting singled out. It's just it's part of really the curriculum at this point.
Mm-hmm.
We have a resident lounge. I'm sure every program does, but the few core faculty that we have at our campus, we do what we call stock the lounge. So we'll go to the grocery store and stock it with snacks and drinks and Red Bull and some healthy, some not healthy. And so they can just like have a place to go in between consults, or if they're stuck there in the middle of the night or things like that. So, I mean, those are to name a few, right? We do team building and all that kind of stuff. But I think that we're trying to create an environment of, take care of yourself, because if you're not taking care of yourself, then your performance at work is going to suffer. The patients might suffer, right? Because the patient care is not going to be quite as good. So.
Yeah, I completely agree with that. If you're not taking care of yourself, how can you take care of others? So
Yeah.
I think that's fantastic. So it's good to hear that there are initiatives, because I know that wasn't commonplace in the olden days, right?
No.
And then over time, it's kind of morphed a little bit. So it's good to see that thought process is at the forefront. Not saying everyone gets to slack off and not do their work. That's not what we're saying, but kind of balancing the two is important. So that's fantastic. Let's talk about research for a minute. So in your program, how do you view the benefit of research to the overall growth of the resident?
So we have a pretty robust research program. So I'll start by just explaining it, and then I'll tie into your question. So the residents all do two projects. One's usually a case report, it's a poster they turn into a paper, but the other one can't be. So it's usually a retrospective study. We have like 20, 30 years of EPIC data that it's really easy to pull CPT codes and kind of compare different things. So that's typically what they do. But we have a whole research team within our orthopedic department that helps us with that. So we have our own statistician, and we have other research support. So they're helping with the IRB protocols. They're reviewing everything. They're kind of like a liaison between, the research and the resident, and they're always with a faculty member as well. So there's a lot of support. We present every year at ACFAS, at APMA, and then there's a more regional Pennsylvania conference that's associated with the Goldfarb Foundation. It's part of the Pennsylvania Podiatric Medical Association. So every year our residents present at all three of those conferences. And that, I think, really helps to grow them as a resident. It allows them to go to the conferences, right? They are eligible for funding outside of their CME money if they're presenting a poster or a manuscript. So $1,500 every year, they're eligible for, not coming out of their CME money if they're presenting a poster. They're networking, they're traveling, they're able to go to these conferences, and they can put this on their CV. We've had residents the past few years giving oral presentations at ACFAS on their manuscripts. So I just think it's really an incredibly valuable experience for them in so many ways.
Yeah, I agree with you. I think you touched on some really good points there, and I think that is beneficial for their growth. And I think one of the hardest parts of research is the biggest question is, well, how do I do research? If you teach them the basis of how to do research, then when they get out into their wherever they're going to go after they leave the nest and they understand the basics of, okay, here's what we do. We start with some IRB approval, or first you think of an idea, then we get IRB approval, and we go through this process and we just kind of go down the line. I think that's beneficial, not just for while they're there, but the potential that they're going to have down the road to understand how to do research. So, and I think that's the basis of medicine. That's how we learn to do what we do. Some people like me just start doing things and then I say, hey, yeah, it works. And they're like, hey, go away, guy. You don't know what you're talking about. Where's the research? And so the research is super important to be able to prove, hey, this is what we do. This is why we do it. This is what works. This is not what works. So teaching them on that resident level, I think is super beneficial. What do you think about jumping into some cases here?
Sounds great.
All right, let's jump into a couple cases here. These are your cases that you've performed. Why don't you talk us through this first one here?
Sure. So just a disclaimer, I picked two different Charcot cases done at two different times in my career. So this first one was really a pretty early on, and the second one was more recent. And eventually I'll point out to you some of the differences and things that I've changed a little bit over the course of time. But this was a 55-year-old male, goes through his A1C and had Charcot and underwent total contact casting.
Mm-hmm.
Ends up getting like a necrotizing infection, undergoes IND, full thickness skin graft with plastics. So then at the time that I see him 2 years later, he just has this recurrent wound. It heals, it opens, it heals, it opens. It's probably a similar story to what many of us are seeing. Here's his x-rays. You can see all that forefoot varus. The heel alignment actually wasn't too terrible, but a lot of forefoot varus. And he came to me as an opinion of, I can't get this wound to heal. He was appropriately offloaded and had appropriate good wound care.
So his wound's at the midfoot then?
Yeah. If you go to the next slide, I think it's the lateral. You can see right there, stepping right on that cuboid, right? So, so that's where that wound is. When I met him, it did not probe deep, but I don't know the whole history of this necrotizing infection. Could he possibly have had bone infection at that time? So I'm not suspicious of it when he originally presented, but certainly it was something that I wanted to make sure I ruled out with my treatment.
So for anyone just listening, I mean, we have a pretty classic Charcot kind of forefoot on the midfoot translation where kind of everything distal to the naviculo-cuneiform joint is translated dorsally. The entire forefoot is up, and you have that classic rocker bottom deformity. So what's your plan for something like that? Because when you first see that, and when I see this in clinic, my first thought is, oh no. And then you start thinking, all right, what am I going to do about this?
Yeah.
So what is your thought process when you see this x-ray and you see this patient and they know they have a history of infection and diabetes, they're complicated, they have a wound. What is your initial thought process of how to work this up?
Yeah, so I secretly love these, maybe not so secretly, I publicly love these types of cases, the kind of difficult train wrecks. But I guess my first question in my mind is, do I need to stage this or can I do this in one stage? And in my hands, open wound is automatically staging for a couple of reasons. One is I'm going to want a bone biopsy. I'm going to want to make sure I can prove there's no infection or clear any infection. Two is I want that wound to heal. And typically once you offload them and affix it or, jumping ahead a little bit or correct the deformity, the wound's going to heal pretty quickly. So that's kind of my first question. For one stage or two stage, really is depending on absence or presence of a wound and possible prior history of infection.
So first stage, like you said, is trying to determine infection level. And then how much correction are you doing during, I assume we'll get there, but the first stage is starting to do some stabilization, maybe some sort of correction, with stage two being the definitive fixation. So what are your thoughts on that initial stage one of how are you trying to obtain all of your correction at that point?
Yeah, I will typically try to obtain most, I guess I would say. And I'll with that prepare myself so that the second stage can be done percutaneously. So I'm usually doing my joint prep or my osteotomy or because if I have to open it at all, maybe to correct the deformity or then, I want to try to set myself up, like I said, for more percutaneous down the line. So this image is, you're probably like, what are you looking at here? So that's two malleable retractors, one across the top of the foot and one across the bottom of the foot. And there's a small incision on either end of that foot. And then the Steinman pin that's going across is really just my osteotomy guide. And I'm just breaking right through that midfoot. This is with that first stage. We did bone biopsies. I did a TAL. But then this is really the bulk of the deformity correction is this osteotomy across the midfoot.
So then you've staged it after you've done your midfoot osteotomy. You're trying to obtain the correction. You're trying to bring the forefoot back in line with the rear foot.
Yeah, exactly. So this patient's bone biopsies did come back negative, and the wound healed up within maybe 2 weeks. So what
would you do if it came back positive? How would that alter your treatment plan?
Yeah, so if it came back positive, the difficulty in this is it's like this midfoot Charcot area, right? It's not as simple as it's this one discrete bone or I can resect this one portion and clear it. In my hands, typically I can't clear midfoot Charcot bone infection, right? So I'm assuming that it's still there. So if this did come back positive, the patient would receive a PICC line with infectious disease. I work really closely with them. They would get 6 weeks of IV antibiotics. And then I try very hard not to put infix back in if there's positive infection. What I've done before, and I have a patient right now that has internal fixation in, she's getting suppressive antibiotics for 8 months, whenever, until I can get consolidation, and then I'm planning to pull the internal fixation. I've just found late blowouts with these patients. I'll treat them with 6 weeks of IV antibiotics. I get clean pathology. I get clean bone biopsies. I put internal fixation in, and then down the line, and it's late. It's 3 years down the line, 5 years down the line, I end up having a problem. So trying to treat this without any internal fixation would be a high on my priority list if it came back positive.
Yeah, so I think some would call that kind of a chronic latent infection. Some people believe that you don't really ever eradicate the bacterial load. You just decrease the bacterial load enough that it's not symptomatic, but there's always bacteria kind of hibernating in there at some point, which would explain why it has a potential for sneaking up kind of years down the road.
Absolutely. That's what my infectious disease colleagues will tell us all the time. So they're always really trying to encourage us, and if it's infected hardware, to pull all of it, not just the side of the foot where the infection is. So then this was stage 2. The beaming was done percutaneously. I did do some small open incisions at the toes to straighten the toes. One thing I want to point out here is that I did not use the subtalar joint. And again, this was back, I think, 2013, 15, around that range, maybe 15. And that's something that I routinely do now on all of my midfoot Charcot patients. So just something that I'll talk a little bit on the next slide and show you that. But this patient did well. I still see him. I think it was 2015. I still see him periodically for diabetic shoes. I can get a wound on the opposite foot at one point in time. So he's still going strong with this, but fusing the subtalar joint is something that I'm routinely doing and built into my Charcot practice at this point.
I think that's good. I think that's why we like to go through these cases, because as beneficial as it is to see what you do, it's also beneficial to see what did you used to do? How did you change your model? What did you learn from what you used to do? There's plenty of things I used to do. Like, I don't do that. That doesn't work. Nobody ever told me that, but it doesn't work. So stop doing that. Now do this. And that's the benefit of learning from people who've done a lot of whatever it may be. So there's his wound healed.
Yeah, so I show that slide that shows his full thickness skin graft from that original necrotizing infection with plastics, and showing his rectus foot there.
All right, you want to take us through this second case here?
Sure. So this patient has alcoholic neuropathy, which I find more challenging to treat than diabetic neuropathy. Diabetic neuropathy, I can say, we need your A1C less than 8 or less than 7. I can, work with an endocrinologist to manage their medications, but alcoholic neuropathy tends to be a little bit more challenging. Never mind the, the long-term management with bracing. Nothing's covered by insurance, right? So I do find these patients a little bit more challenging. The patient also had rheumatoid arthritis on methotrexate, had painful Charcot. He at the time was 6 months sober when I met him, and he works as a chef. So he's on his feet all day throughout the day. So this is bilateral. The left clearly looks worse from the Charcot standpoint, but the right, he's got this non-union of his navicular and more collapse and a little more, looks a little more impressive on the lateral.
Yeah, I think that's a patient that's set up to be a complete headache. I agree with you. The alcoholic neuropathy, these patients tend to be a lot skinnier than our diabetic neuropathy patients. I don't know what it is about the alcoholic. I'm sure it makes sense nutritionally or whatever, but they tend to be very skinny, and they tend to be almost kind of a little more frail. They're almost just kind of like not a lot of soft tissue coverage, and they tend to be kind of thin skinned. And it's just, when I hear that and I see that, I just think, oof, that's tough.
Absolutely. I agree with you. And that is this patient. Everything that you're saying is you're describing this patient to a T.
Yeah.
So this patient had no wounds, no history of wounds. So right off the bat, then I'm looking at this differently and thinking one stage. But he also has a bilateral problem, right? So I'm kind of talking him through which foot do we do first? What's the minimum time frame from one foot to the other? Making sure he has family support and all of that.
So what is it we're looking at right here? Is this kind of like coalescence of some Charcot breakdown, or what is that in
It
the
is.
midfoot?
It is, and I'm glad that you bring it up because it's so tempting to try to make that look perfect intraoperatively, right? But guess what's right on top of it? Your neurovascular bundle.
Yeah.
And I remember being in the case, and I got a lot of it, and we'll see that in subsequent slides. But I remember the resident saying, "Well, there's still some there. Don't we want to go after that?" And I said, "No, I don't. It's not going to change the patient's outcome.
Yeah.
That's not bothering him."
Right.
So I think that, but yes, it's coalesced Charcot bone. This was
Hmm.
a pre-op MRI that I got to see that I was trying to see if the navicular was viable,
Hmm.
where that non-union was, or if there was any sort of an AVN component to it. And so I did determine that there was some viable bone that we would be able to keep.
That looks very chronic, though. That looks
Oh yeah.
very like the bone is almost given up. It's like we used to
Yeah.
have some inflammation in here, and didn't work. We're
Yeah.
going somewhere else.
And then this is his clinical picture. You can see all that callus and hypertrophy that's building up along the medial arch. Again, he stands at his job. And although we don't typically think of Charcot as a painful pathology, in this particular patient, it was painful. So this is a final follow-up. The original side that was performed was actually the right. So he's about 1 year and 10 months out on the right. And on the left side, he's about 10 months out. And treated a little bit differently. The left side had some lesser ray beaming performed, whereas the right side didn't. But on the right side, I had to completely resect that non-union. I almost kind of popped out the navicular, took out a middle section, used some bone graft to fill it back in, and did a combination of beaming and plating on this patient. I like beaming and plating in situations where I have it open because I'm prepping. It's prepped anyway. So I'm able to place the plate, but I think that dual construct together makes it a little bit stronger.
Yeah, I found that I agree with you. If you're doing beaming and plating, I think it does tend to be more stable. I found that the ones that are ripe for failure have been either not extended far enough. So if you just limit your plate to right there in the middle and the cuneiforms and the navicular, it's most likely going to fail. If you extend it distally into the metatarsal and more importantly, proximally to the talonavicular joint, it's much less likely to fail. I think that including the talonavicular joint, at the very least in this case, is very, very important. So spanning that widely beyond the area that you're actually working on seems to fail less than if you just focus on the area, if you get too narrowly focused.
I agree completely.
So how did that kind of turn out for him? Because you got a lot of metal in there.
Yeah.
You turned his bone into metal.
Yeah, and then I just want to point out too some of that dorsal spurring. So you can see it's much improved, but there still is a lot of it there. And there's that point in surgery, right, where you need to make the decision of when to stop. Also pointing out that I fused his subtalar joint on both sides, and that's a really important part of my construct now for midfoot fusion. So he's doing well. He hasn't broken down. He's pain-free. He's ulcer-free. He's ambulating independently. I do lock up the patient's ankle joints at least a minimum of 1 year after surgery. And since he was bilateral, even on the side that he's pushing 2 years out on, I still have him in an Arizona brace on that side. But again, it's challenging because he's not diabetic. A lot of these bracing devices are out of pocket costs, and they're not cheap.
So what's your thought process for maintaining the ankle joint in that you didn't fuse it, but then locking it up with the brace post-operatively? What is your thought process for that?
So I'm trying to get them through at least that first year. And I'll tell them this right from the bat, you're going to, and sometimes it's a crow, sometimes it's an Arizona brace. We're going to immobilize the ankle for the first year. And if we can get you through that, and our stabilization in our foot is, it's solid, our hardware is good, we've got at least pseudoarthrosis, if not a fusion across the joints that we're trying to fuse. We're ulcer free. If we can get through all of those milestones at 1 year, then I'll start to think about downscaling. But I have a patient that she's very active. She's a single mom. She's a nurse practitioner, and she's got Charcot. And her biggest complaint is that her ankle's stiff. And it was a similar case to this. And I look at it as, this is such a successful result. Her wound is gone. It hasn't come back. She has no pain. And in her mind, she's unhappy because she wants more ankle motion. So sometimes it's difficult to, to explain to patients that that's never going to be our goal, right? In fact, we're trying to limit that.
Yeah, I think patient expectations are a huge part of this, including putting BKA, below knee amputation, on the table. And as soon as you set the bar with not having a leg, I think you kind of open the idea up to anything we're able to salvage here is a win. So expectations do factor into that, because it's easy to say and it's difficult to obtain, because I have conversations with patients all the time where I know what I said because I know what I said. And they may leave and say, he said this. And I'm like, no, what? How did you get that out of what no, I didn't. That's the opposite of what I said. Were you listening? And so communication with these patients, you're going to become best friends with these patients, whether you want to or not. You're going to see them a lot. They're going to be coming back post-op visit after post-op visit. Okay. Then they get a little wound dehiscence here, and they get a little suture reaction there, and they get a little infection over here. And then, one little screw breaks over here. They're going to become family. And so communication is of utmost importance. So I think setting those parameters from the get-go is important. Let's go back for a minute on this guy and talk about, let's go back to the first one real quick, and then we'll come back to this one. Do you have a cutoff of a hemoglobin A1C that you are mandatory? Like, hey, even though you've got a wound, we should probably get to this at some point. Do you have a cutoff for your hemoglobin A1C that you say, this is not a good idea, I will not operate on this?
Yes. If it's stable, that I can wait less than 8.
Okay. And if it's unstable, infected, you just got to clear the infection and stabilize the best you can and cross the other bridges later. What about this guy who's on methotrexate? Does that prevent you from, because, obviously that's going to be a complicated medication for someone on an RA that's going to be immunosuppressant, and obviously that's how we heal. What are your thought processes on that?
So I work with the rheumatologist, and I put that decision, I won't make that decision personally. And I found a little bit of variability. I've had some keep patients on methotrexate. I've had some hold it 2 weeks prior and 2 weeks after. Sometimes I'll be more opinionated than others, right? If I'm doing an Austin or a hammer toe, I might be less opinionated as opposed to a procedure like this. But working with rheumatology, they did hold his medications perioperatively.
Okay. Interesting. Because I think that's a kind of a complicating sticking point for some of these patients, because it's easy for us to sit back. And I do this with the students who are with me. We sit back and we look at x-rays, and it's easy to say, well, I'd fuse this and then I'd put a screw over here and I'd do that. And you're like, wait till you get in there. It is not nearly as easy as you think that it's going to be. And the same thing with managing their medications. Well, I'd put them on this and then I'd do that. And you're like, well, that patient lives alone and has no way to get to your office. Now, how are you going to change your patient treatment options? Like, it's just, everything is more difficult than sometimes that you think that it's going to be. So any parting thoughts on these cases here?
Yeah, I think that on the same train of thought that what you brought up, the patients that have a family support do better, because this is a commitment. And I try to tell them, this is not, 2 months, a couple months, like you're committing to at least a year. And that's if it goes well. That's if we don't have complications, if you don't have to go back to the operating room. That's in a perfect world, and these typically are not perfect world cases. So I find that the patients that have more family support, a spouse, a friend, a neighbor, somebody that can come with them to the visits, reinforce some of the principles and things that we're telling them, they really do better.
Yeah, I think those are great thoughts there. So thanks for sharing those cases. I think those are good learning points for those listening. I do have a question before we wrap this up for you. So you're in Scranton. Do people in Scranton love the office, or do they hate the office for making Scranton look different than what Scranton really is?
Oh, they love the office. We have an office 5K every year where everybody dresses up like characters from the office. There's murals of the office characters all over our buildings downtown. So we are.
They embrace it.
Yes, we embrace it.
All right. That is awesome, because I'm a huge Office fan. So that makes me happy. I'm going to have to come visit and check out some murals sometime. So thanks so much for joining me tonight.
Oh, thanks for having me. This was really wonderful.
Yeah, absolutely. So joining me, Dr. Ellie Nasser, Residency Director at Geisinger. If people want to find out more about your residency or the extern process, where would you send them?
Sure. So they can email me. My email is M. Nasser, Nasser, at Geisinger.edu. Or you can follow me on Instagram or message me on that. It's at Dr. Nasser DPM.
Awesome. Well, thank you so much for joining me tonight.
Thanks for having me.
Absolutely. Thanks, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.